Welcome everyone to the May board meeting of NHS Direct NHS Trust. We are, as usual, online. I'm looking at the back of the room. Yes, we're online. If anybody who listens to us online would be kind enough to fill in a feedback form, that would be great. Enable us to continuously improve your experience. I'm not sure that this meeting is going to be incredibly long. Might not be a long one. Usual items. We are going to start with apologies for absence. Trevor Jones isn't, Deputy Chair is not with us today, and Louisa Dillner may be able to dial in for the private part of the meeting, but she's not going to be able to be here in person. I haven't had any declarations of interest. If anybody wants to make a declaration, they're very welcome. No? Okay. Then let's go to the minutes of the last board meeting, which is 30th of April. Are there any matters of accuracy in the minutes? Whoa. Okay, so I think I saw Trish and then Sarah.
Just a question, Chair. In 9.2 on page 4, it says, and 3 other executives. I think with Nick being named as Chief Executive, it was just Keith and Di. So it's a further 2 executives.
Fine, so that's just a slight correction there.
Yeah.
Okay. Lovely. Sarah?
And 13.1, it states that I presented the report, and I was actually on annual leave.
Yeah, you were there. The report presented itself. No, I think someone ably stood in for you. Can you remember who presented the report? Yeah, Nick, I think you presented
Obviously, I remember doing that.
So that's fine. Excellent. Okay. Then let's go to the action list.
I think it's fairly succinct. The first two items that are due are on the agenda, so we'll pick those up when they come up. And the third one, that Trish's action, we'll send a note around rather than, and that's happened.
That's complete, yeah. I'll send a note round.
Okay, thank you very much. That's great. I'm happy to take any questions on my recent engagements, which have all been jolly interesting, actually. If there aren't any, we'll go on to the Chief Executive's report.
Okay. Just the first item on staff open forums. I think we've now had about 500 or 600 staff come to the open forums that we've had around the country. The general pattern is we've been doing them sort of morning, noon and night, so that to fit in with staff shift patterns, obviously, and quite a number at the weekends. So there's been good geographic coverage. We haven't got everywhere yet. There's another couple of weeks to go. I think generally, but I mean, a number of non-execs as well as my exec colleagues have been involved in the meetings that we've had to date. I think by and large, people have been very appreciative of having the opportunity to hear the board level view of the organisation and where it is and what the implications are. Mostly staff have heard almost everything that we talked about on the grapevine, or and they're not quite sure whether to take it at face value, what they've heard on the grapevine, and actually having the opportunity of a decent amount of time to sit and listen to a presentation and then have a good long discussion. Most of the open forums have lasted about 2 hours, so staff have had a good opportunity to debate it, really. So I think it's very useful. It obviously hasn't removed uncertainty from staff, because one of the central messages we're going out with is that there is a great deal of uncertainty, and here are the reasons why. Hopefully here is a timescale that will enable us to make that uncertainty look less, but our commitment is to keep in contact with you and to keep the communications going. So I don't know if anybody else wants to say anything about the open forums.
Roger.
Chair, could I acknowledge the role that non-executives have been playing in this process? This has been way beyond the call of duty for them, and some of them have had to go a long way out of their way to join these meetings, and their presence has been really important, I think, both to support the execs there, but also for colleagues in the contact centres to see their non-execs, to know what the role they play in the organisation. But I think the commitment is enormous to get to these disparate contact centres across the country. So I think that should be acknowledged.
Keith and I are off to Chatham tomorrow,
Yeah,
which I'm looking forward to. Does that mean that we've managed to field non-executives at most of the forums?
Most of the ones that I've been at.
Okay,
All
good.
of the ones I've done tomorrow, the 4 that I'm doing tomorrow will be the only Ned presence, but that's just the way that cookies crumble.
But we think we've got reasonably good
Yeah,
coverage.
I think we've had
Okay,
reasonably
good.
coverage.
Tim?
I think the second note that Jodie's put out with the smaller sites, she's having a little bit of difficulty. I was looking at it on Saturday afternoon.
Okay, so we will presumably struggle with those a little bit.
Yeah,
But,
I think
okay, fine. Thanks, Roger.
Okay, so I have mentioned here the fact that a draft of the Sheffield evaluation of the 111 pilots has been produced. I've been amongst a few people on the 111 programme board privileged to be able to read it, but I'm not able to talk about it, and therefore I won't, other than to say that I'm hoping that it will be published soon.
Nick, I'd like to ask you a question about that.
Yeah.
So, the draft has been prepared and is being circulated on a very limited basis.
Yes.
How does the timing of that and the publication of it work with the creation of tenders and bids? I mean, is it given that the bidding process is very far advanced, how is the evaluation going to help the people commissioning make good commissioning decisions if it's not available yet?
Well, one would imagine that it will give commissioners the opportunity to consider its implications before signing their final contract. I think that there are very few contracts that have actually been signed, and it may give commissioners some useful information to consider in their contracts.
But presumably OG
Negotiations.
rules would mean that they can't make any significant changes.
Well, I think that's up to them.
I mean, is it? I know we haven't seen this document, but I mean, does it actually? Is it a sort of boring academic treatise, or does it actually sort of stimulate ideas about the way the process of 111 procurement might be improved?
It's 187 pages long currently.
Wow.
But it has a short.
Does it have a suggested action?
It
plan
doesn't have an
or
action
change?
plan, but it does have an executive summary for those that don't want to read the full detail. I think it's hard for me to go any further than I've already gone.
So it doesn't sound as though it picks out.
I think you're leading the witness.
So it's unlikely to help people pick out their views. That's as open as I can get.
I think you've had a bunch of academics looking at the 111 pilots, and the sooner that their findings are published so that people can read them, the better, in my opinion. Whether or not that means people can actually make changes to their OG style procurements, I mean, I suspect that they can, frankly, and in the final analysis will, if they think it's in the interests of their local health community. So the sooner it's published, the better.
I've got Tim and then Steve.
So, should we record that this board would welcome the publication as soon as possible?
If you agree with me, yeah.
We do, I think.
So should we put that? I mean, I don't know whether there's anything that we can do to encourage the publication.
Yeah.
But
We're
we
just
can at least
reiterating a
record
position that we've taken, all the way along. We believe that commissioners need to be have all the information that's available to help them make good commissioning decisions. My query would be whether the timing of this is tremendously helpful. Steve.
Without leading the witness, if the report was to lead some commissioners to think that maybe they want something different to what they originally intended, could the tenders process be reopened, or is it too late for that?
I think until you've got a contract signed, commissioners can make decisions that are in their local health community's interests.
Thank you.
And that's what history tells us commissioners do when they have information that's of relevance to the decisions they've got to make. And the sort of rules is rules. We've got to stick to the thing that we've already started. Well, in my experience, that isn't what happens if there is sufficient weight of thought and evidence that suggests you should do something different.
Thank you very much.
Okay, good. Thank you, Nick. Do you want to carry on?
Yes. So, also in the slight hazy world of telling you some of the details, but not being able to disclose all of them, we're in the process of having meetings with the Department of Health to go through the details of potential decommissioning costs for 0845, the implementation of Cabinet Office guidelines, and I will report briefly on that in just a second, and the likely dates for handover of 0845 responsibility to 111. I just want, though those discussions have not concluded, I wanted to bring those to the board's attention and to reiterate that until we have had a board discussion and agreement, we won't finalise the trust position until we come back and brought those back to the board. So the one thing I was going to add was I'm very pleased to say that I had a meeting with Richard Barker, the newly appointed Regional Director for the North, but currently the Chief Operating Officer for the North, NHS of the North, plus Simon Featherstone, the Chief Exec of North East Ambulance, and Yasmin Chowdhury, the Cluster PCT Chief Exec responsible for the commissioning of the 111 service in the North East. And we have now agreed the implementation of the Cabinet Office guidelines in the North East will take place with the numbers of staff included in the arrangement as per the national formula and without selective competitive interviews. So we've got that commitment.
That's very good news.
It is.
And took a lot of effort.
Yeah. So, and finally, we've started 2 pilots, both of which the details of the findings will come out in reports that the Department of Health will have ultimate say over. The first is diverting our 0845 calls through the 111 service in Luton, and so that this will mean we will have information relevant to what the world looks like when you've switched off 0845 and everything's being handled through the 111 system. And that started on the 9th of May, I'm pleased to say. And the second is the digital prototype, which the board is aware, and that pilot is working through the theoretical and practical possibilities for a web-based multi-channel type element to 111, and we expect a report to go to the department in September or October.
But just to be clear, the clinical content in that web-based pilot is our...
it's based on the health and symptom check.
It's not based on the pathways content.
Correct.
So
Yeah.
it's not a web mirror of the pathways 111 system. It can't
Correct.
be.
No,
Okay,
that's right.
fine. Nick, could I ask you, do you want to say anything about the information strategy which has been published?
Yes, so good, a good prompt. The information strategy was published actually just after the my chief exec's report came out, so that's my excuse for not putting it in, but thank you for reminding me. The report is, I think it would be fair to say, it gives a vision of what the information strategy for the NHS should be, rather than a detailed programme of centrally led activities to produce a set of deliverables. The report itself I think makes the case quite powerfully that there are very considerable improvements in healthcare service delivery that can be supported through the use of digital information technology, new technology means, and it's littered with examples of local organisations delivering their own particular service improvement using IT as an element in the mix. So I think what the report at its broadest level, the strategy at its broadest level, is suggesting is that there are substantial improvements that can be made to information strategy. These are going to be largely delivered locally rather than through national programmes. There are some relevant national commitments, including access to GP records, and it's described as a single online portal for the NHS where patients can go to gather useful information, best of health information and care information. NHS Direct gets us a brief mention through our piloting of patient decision aids, which is ironic given where that went, as we no longer provide those. However, I think it does open the door for NHS Direct to be a supplier of information systems, for example, the health and symptom checker type approach within this single NHS portal.
Yeah, so subsequent to the strategy being published, Nick, there's been some further interviews and press speculation and commentary, amongst which there's been an exploration about what this portal really means, and there's been a very specific statement, I believe, that the brand hasn't been decided, what it's going to be called hasn't been decided, who's going to run it hasn't been decided, so it's pretty, visionary is probably a good word, rather.
Yes.
It's a vision, not a strategy.
I think we can be clear, it's not going to be called the NHS online portal, hopefully.
Nothing would surprise me, but
Yeah. So I think there is an awful lot of detail that is absent.
Mind you, the name of the information strategy itself is a mouthful to come through with, and if you took that at face value, it might well be called the portal. I don't remember the strapline, but it's something very, doesn't trip off the tongue quite as well as one might have hoped. So, yeah, I would agree with your analysis, Nick. It's very helpful. Has anybody else got any questions about that or thoughts? I'm sure other people have been looking at the coverage of it. Tim's got a copy of it in his hand. What's the strapline, Tim?
Oh, putting all of us in control of the health and care information we need.
Thank you.
It's a mouthful, and it's also a bit of a read. I was a bit disappointed not to see more mention of NHS Direct, to be quite honest. And I think it's also disappointing that the next step is to work out how this vision can be implemented and what can we do to put ourselves at the centre of working out what that is a question I don't think we've got an answer to, but I think we ought to give some consideration to that.
I think the team's engaging to the extent that it can.
Yeah, I think the fact that our health and symptom checkers are the second most popular reason that people visit the current NHS Choices site puts us in a position where people are interested in what we have to offer for the future, and building on that kind of experience. I think we've got a very positive contribution to make. I think that's recognised, to be honest, but it's in the context that I think there is little appetite for a large, centrally run information technology programme for reasons that I'm sure the board will completely understand.
Yeah, I guess that's a different issue, I think, from whether NHS Direct is at the centre of working out what this thing means. It doesn't have to be a large, centrally run, technology-enabled programme, actually. But
we hope to be able to contribute.
Yeah,
it's probably the best way.
And we are engaging in that, both through the web pilot and through discussions about the health and symptom checkers specifically.
Alan,
I think I'd add just on the positive side, it includes a number of sort of design principles, and I think if you set out quite formally what those design principles are, then that will actually aid getting more common approaches to the way in which systems are developed in support of healthcare. So, such as patients being able to gain access to their own care records. And I think if you try and pick all of those out, then you get quite a number of sort of guiding principles to underpin development.
So it is a document, isn't it, about vision and principle and standards, which in its own way is quite helpful. Okay, good. Are there any other things that anybody would like to ask Nick about? No, not this moment. Okay, then let's move on to the performance package, which, as usual, Trevor will introduce. Trevor, do you want to do performance and then finance?
Yeah, certainly, Chair. Very brief headlines for the April performance. As previously noted and discussed last month, our performance over Easter was good. Our biggest issue remains nursing numbers, which has impacted upon our clinical assessment rates for both less urgent and non-urgent clinical calls, and does restrict the volume of calls that we're able to safely take into our service. We were therefore again below planned numbers for calls in April, but we've remained within target for our abandonment rate and for urgent clinical assessments. So I'll pause at that point and take any questions.
Are there any questions on the performance package? So the traffic light report and all the supporting graphs. Sue, and then Steve.
It's not necessarily a question, but it's just I was interested to see the new KPIs. This is really the first time we've had the rostering efficiency metric and the schedule adherence and the fulfillment capacity. And I guess I welcome those because I think they tell a very important story and will allow us to sort of understand metrics better and performance better. Am I correct in thinking that the rostering efficiency metric at 88.5% is significantly better than we've been achieving prior to the changes in the...
It was typically around 73% previously.
Okay, so at 88.5, we've got over 90%.
Yeah.
We're hoping to get 90 to 95. Is that reasonable expectation?
It is. So generally the rosters are around 90.5% when they're released.
Right.
There will always be an element of degrading from that once they've been released, why then you're allowing for some shift slides, some emergency annual leave, and smoothing out the edges with breaks, etc. Previously, when rosters were released, they were degraded by 10 or 20%, which would take us down to 73%. So the number that we see here at 88.5% is the actual. So they would have been planned at kind of 91, and we actually achieved 88.5.
So even very, very little. That's excellent. And the other one was the expert core reviews at 79%,
really noticeable.
which is fantastic to see. And I know is a product of a huge amount of focus and attention by the
Well done. Well done. Agreed.
Steve.
Well, it's just really to square the comments on the front page that the sickness levels decreased with the graphs on sickness levels, which seems to go reverse actually. Page 8 and 9.
I think it should say long-term sickness levels decreased because the overall sickness level
Well, it's increased according to the graph. It's increased.
Overall sickness has increased. Long-term, it should say long-term sickness has decreased. Overall sickness has increased.
The graph in April shows an increase.
Yeah. So I think we've got at least 3 metrics kicking around here because
yeah.
we've got the number of people on long-term sick leave, which is also kicked up.
Yeah, no, that's true.
Just Steve's point is those three, the different metrics have
all pointing in the other.
So that's a mistake in the
comments.
Yes,
okay. So we'll get that corrected.
So I'm not surprised given the changes that we've made and the rostering, etc. I guess, but we ought to be aware of this.
I'm going to build on that and then ask for. I'm going to jump in front of Tim. So because our targets kicked up as well. So was that. So the 3 targets that seemed to kick up were calls requiring onward referrals, sickness, and number of staff on long-term sick leave. Was that an expectation due to the rostering changes that we were expecting?
No. Our sickness target has been for the last 2 years 10 days per employee per year. And frankly, we haven't got close to that, so we increased that to 13.
And I presume that that's a typo on the key on the graph B25. It says completed in NHST target. That's just a typo.
So can I just fill in a little bit more about the target on? So when specifically Keith building. A capacity plan for the forward year, we ended up agreeing a different practical metric level of sickness to build that capacity plan, because if we built the capacity plan on a target that we knew we weren't going to meet,
Yeah,
we ended
fair
up with two different. So what I don't want to give the impression is that what we were doing is saying, oh well, we expect sickness to increase. That's not what
Okay,
we're
I
saying.
understand.
It's making sure that
Got it.
we were actually having a target that we really did mean to meet, because it's built into our capacity plan,
Understand.
and not having different targets depending on which audience we're talking to.
Understand. That's very
That's
clear.
where that was.
Tim.
Right,
all right.
sorry.
Hang on. Let me step back for a second. Tricia, I think you wanted to come in on that. Is that right?
Not on the sickness. No, I
Okay,
want
so I'm
to
going to hold.
cut- yeah,
So
that's
I
fine,
think
Chair.
then I saw.
Yeah.
I think I saw
Tim, yes.
Tim, and then Peter, and then Trish. Is that all
May
right?
not have a comment if he covers it.
Chair, can I add?
Okay, so I've got Tim, Peter, Trish, and Alan. Tim.
You've covered the first bit, which is why the target's gone up for
Yeah.
sickness. But back
That's
to
right.
the rostering efficiency. Why are we expecting bank holiday? Why do we accept that bank holiday efficiency drops? Because I thought one of the key issues about rostering was that we would achieve particularly at bank holidays.
Yes. The issue that we are suffering from still, and we suffered from it this weekend and next weekend, is that all our annual leave up until September was released last March, and the thresholds were not optimised. We've now in the process of releasing our annual leave for the period from September this year, and there has been a big change in how much annual leave we are allowing over bank holiday periods. We have tightened that up.
Okay.
So it's a legacy issue.
Yeah.
Thank you, Peter.
Yeah, I think it's just an overview point. I just see that the organisation is responding well under duress, and that's an interesting fact in itself. I mean, talking to staff the other day, I was impressed by morale. Interestingly enough,
Yeah.
and despite all of the things going on, the numbers aren't perfect, but they are certainly going in a good direction. And long may it survive. But I mean, I didn't detect when I was talking to people that their tails were down.
No, they weren't, were they?
Which might be surprising in a funny way. But so I just want to say that. Also, the numbers around 111 and 0845, as always, show an interesting contrast about in-house and referred on.
Yeah.
I just had, I should have picked this up outside the meeting, but on the number B21 line, it's got the target at 33%. Is it 33 or is it 25? Because if it was 33, we'd be green, I think.
Can Tricia explain the change?
It's a dynamic target.
It's
Dynamic target.
Right. We need. This is important.
which
all
is
to understand
building
this.
on
Oh.
why I raised my hand.
Yeah.
We in discussions in our contract meeting with our commissioner, we have asserted over last year us failing to meet the urgent and emergency referral was based on a target that was set many years ago, and it actually didn't reflect the level of urgency of the callers we receive into the organisation. Board members remember that there is a perceived view that our callers are less urgent than people ringing the out of hours. Our commissioner engaged with us, we gave evidence of that to our commissioner, and we renegotiated that target so it is flexible, and it correlates up and down to the number of P1s we get into the service. So our target is based on a percentage which correlates with the number of urgent calls coming into
That's
the
what
service.
you mean by a dynamic target.
So that's what we mean by dynamic. So the more urgent calls we get, as defined by the proportion that we classify as P1, the higher the higher the proportion of urgent emergency referrals we would expect,
Yeah.
and therefore that's now incorporated into the target. Because it always used to be the case that on a Saturday, for example, you would have a higher proportion of people being referred in on urgency and emergency referrals, because that's the case mix on a Saturday.
Yeah, I understand.
But therefore you'd always fail the target on a Saturday, and it now moves with
Yeah,
the
okay.
nature of the calls.
So shouldn't this be green?
Chair, I'll take that back because there has been no daily penalty at all on that target, so we will look at that. So there are some teething problems.
Non-exec reasons.
All right, Alan. Before you come in, I just want to, because this is my comment is the obverse of that, so the other side of the coin. B20 and B22, the calls that don't require onward referral. So I think, Peter, you alluded to that. I mean, it's just a startling difference between 0845 and 111. So I wanted to, echo that. The second thing I want to say is there not a 111 target? So there isn't. So although there's one in the key, in reality there is no target for 111.
Which is interesting in
which
itself.
Is interesting in itself. Interesting in itself.
I mean, I think there are, within contracts that commissioners are setting, they may set locally set targets, but at the moment the service is delivering our national targets.
Fine. Alan, being patient, thank you.
Okay, thanks. I think there's maybe another teething problem which is probably worth another look, and that is we've reported about the shortfall that we currently have in nurses, but that shows up as us being green on recruitment and retention at 0%, and that's an artifact of the fact that we're over-fulfilled on health advisors and under-fulfilled on nurses. And I think we maybe need to take the average of the modulus.
So we've got an anomaly there.
Yeah.
So thank you for pointing that out. Okay, very good. So I think that the medal for detailed reading of the performance stats was, is very, very hotly contested actually. There are a number of very detailed comments. But just coming back to the bigger picture, I'd like to just pick up Peter's point, which is overall, as a package, we've picked at some of these indicators. We've looked at sickness. We've looked at the emergency referrals, which some which look better, some which look worse. But overall, our performance is holding up creditably under very difficult circumstances.
I think that's right. The way that I've been saying that, I don't know if other executive directors have mirrored this in their presentation to the staff open forums. What I've said is, if it is the case that the last call on 0845 is on the 21st of March, we want that last call to be as good as we would expect any of the calls that we're currently handling on 0845 to be. In the vernacular, we'll go out with a bang, maintaining the service to the last moment and making it as good as we can possibly be, and that's what we'll do. And I see nods around the around the audience when I say that as a kind of, we'll show them, we'll jolly well do it. I'll use other words, but so that's, I think, that's what lurks there. People have pride in what they're doing and are not going to see that taken away.
Yeah, thank you. Shall we then go on to the finance package? Trevor, again.
We ended the month in line with our financial plan. We recorded a surplus of £396,000. We have cash balances of £20 million. Clearly there are a number of risks that must be carefully managed throughout the remainder of the year, and we'll carefully track, report and manage this position as we go forward. I'd also like to advise and I'm pleased to report that the TAL contract has now been signed for an extension through to November 2013.
Very good. Any questions on the finance package? Steve?
2.5, locally commissioned services was higher in April than planned. Is that because of volume in existing services or new services?
Can't recall the exact driver behind that, Steve. I'd need to go and unpick that further for you. But I think it might just be an anomaly of month one position versus year end.
I guess actually I didn't ask the question correctly. What I meant was we're hearing that some PCTs are decommissioning services like that. Have we had any services decommissioned?
Only where they've subsumed them into the 111 service. And Birmingham Home Health is a big one.
Tim?
Trevor, remind me, Capital looks like a very slow start to the year.
With an anticipated low level of spend across the capital programme this year because of the situation we're into.
Yeah, but we are. I think in principle we're making the decision that we protect our ability to respond when we know the outcome of the bids. So that very low number is in line with that principle. We're not delaying anything because we just don't think it's worth starting.
No.
Okay, great. Thank you.
Thank you. I think as a board, we're very lucky that we don't need to spend a huge amount of time on finance. And the reason that we don't is because we have, we are on top of it. Exactly. We have confidence in our finance team. We're producing good numbers. And it's not, it's something that we can almost take for granted. And I just want to pause and say we shouldn't take this for granted. It's fantastic performance. It's a real credit to the whole organisation as well as the finance team. And I don't want the fact that we tend to skate over it suggest that we don't take it seriously. The fact is we don't have to spend a lot of time on it at the board level because it's very much in hand.
Very much.
Thank you. Okay, so I'm going to now suggest an ad hoc change to the order of the agenda. Shock horror. And I'm going to ask that we skip governance and compliance because I'd like to have a coffee break before that. And go straight to stakeholder engagement, if that's okay. Keisha, am I able to do that? Okay. So we're going to having finished the performance section of the agenda, we're going to go on to stakeholder engagement, and we've already started to talk a little bit about engagement visits in relation to the staff forums. I'm not sure there's a great deal more to be said around that, but I would just like to feed back on Louisa's behalf. She went to Milton Keynes for an evening meeting with you, Alan.
She did, yeah.
Do you want to talk a little bit about it, and then I can give you... She's probably fed back to you already, but I'd like to share with the board her view.
The evening session had quite a small level of attendance, probably about 10 or 15 people, mostly nurses, many of whom had worked with NHS Direct for quite some while. And I'd sort of characterise the afternoon sessions, the well-populated, 60 to 80 people, and mostly you got the sense that people were sort of having their suspicions or their prior expectations or hearsay confirmed by hearing in black and white the current uncertainties which NHS Direct is facing. The evening session was rather different. It was sort of quite subdued, and I think it was quite emotional for a number of the nurses who were present. And I would say that the main thing that characterised that emotion was a sense of having come through a journey of 12 years of NHS Direct and learned how to do nurse assessment and advice giving remotely, they were just, they couldn't get over the shock of how different the NHS 111 service is, and how could decision makers have decided that this was the right thing to do. And they just found that very emotional experience. It was quite sort of quiet and subdued session, and it was very fortunate that Louisa was there, because I think she contributed to it very well.
It's interesting. Well, her comments were, I mean, she was very complimentary about the way you handle it, Alan. She said that the materials were good. She talked about the presentation coming across as very open and sincere and realistic as possible, without depriving anyone of any hope whatsoever. And she talked exactly as you have done about the nurses who were there. She said there were other people there, but the nurses were particularly sad about the loss of a service that they felt had a huge amount to offer. And Louisa's comment was that she thought some of the other meetings had talked more about rota frustrations, but that meeting was very much about the loss of the experience of a remote nursing-led service to the NHS. And so in that sense it was less personal, it wasn't so much about individual circumstances, but it was very powerful and moving. Don't know if anyone else wants to comment on engagement visits they've done or about that one. Tim?
Yeah, I went to Southampton with Keith before the forum started, and it was quite, I spoke with the team leaders, and it's very striking that they realised that the organisation's in quite a difficult position and we got some big challenges. I asked them directly what they wanted from us, and they said honest, direct communication. Not that we're ever dishonest, but I think the requirement for the communication to be very high quality, very direct, and to spell things out was clearly articulated in a constructive way, because it was the team leaders were saying, if you do that for us, we think we can keep performance to where it should be. Very, very, very constructive. And so I was quite delighted. I hadn't seen the forum material before then, and I hadn't been to any forums before then, but I think the material is can be seen as very honest and very blunt and very direct. And so for me, it sort of answered the question that Keith's team down in Hedge End were asking for. So it's good. So I think we are delivering on that. And I've been in, where was I? It's all a blur. I was in Dudley on Friday and Middlebrook on Saturday, and I think everybody appreciated the fact that we were spelling things out and being supportive and being very, very clear. And I think the forum pack is a good pack, and it's well delivered.
Should I say?
Peter Vinton.
Should I say? I mean, all of those sentiments reflected in Bedford, where I went with Roger, and I think the material is good. I think the difficulty is explaining entirely where we are, and that became quite an obscure conversation in a way, because we're trying to be honest, but we can't actually spell it out totally. And I think that's something which I think they got it in the end, but it wasn't easy to explain it, was it? But as I said, the only thing to add really was that I didn't get the impression people they might have been down to some extent, but they certainly were looking for what can I do, how can I progress myself. There were lots of upbeat things as well, which was good, and there's an opportunity to say thank you to people as well, which was even better. And people do understand the context of the country's position as well. I mean, that was the other thing, where it's not sort of picking on NHS Direct or anything like that. It is actually a national problem that's being dealt with, and NHS Direct is in the middle of that, like many other public sector organisations. Thanks.
Thanks, Peter. Tim.
Yes, I was in Wakefield with Nick, and then after attending a couple of the open forums, I was able to then go and talk to some of the staff and listen to a few calls. And some of the staff I spoke to where staff had been in the forums, so I got their personal and one-to-one views about what they'd heard, which I think reflect what we've heard already, that they're very grateful for the forum and understood the predicament that the organisation faces. So that reassured me that the approach in the forum for that group of staff was an excellent way of doing things. There are a couple of things that I picked up outside the forum then while I was there. One disappointed me a little in that there was a lot of concern about inability to get to training still. Because I had perhaps naively thought that one of the objectives of the new rostering was to roster in the training as well, because we know that it's constantly cancelled. And it wasn't entirely clear why that was so. And the team leaders I spoke to weren't really clear. They said they turned up of a morning having scheduled training or one-to-ones, and there was an email to say, not today, folks, without any real opportunity to reschedule as well, or they said it's extremely difficult to reschedule. So that was one comment. Another thing, this is the first time I had spent time with health information staff, and I thought that the scripts they read from were unbelievably good and clear, and makes me wonder why we can't move towards providing that information directly. If we're not allowed to maintain health information staff in the new world, why can't we use that package of information which has been built up and which looked to me excellent for the 3 topics that I saw while I was there, and make that available somehow. So commercialise is probably not the right word, but to somehow let the NHS benefit from that. And my final observation was thinking again about 111, and that I heard 3 calls with a extremely good health advisor, one of which went off to a dental advisor, one of which went for a 999 ambulance, and one of which went to a nursing advisor, showing the breadth of what we do. Very efficiently, very neatly, absolutely appropriately in my clinical view. We're not going to be able to do that in the new world, and they would, well, the dental patient would have suffered, presumably, because there would be no help. The A&E patient would have ended up in A&E pathways, I'm sure, and the nurse advisor probably would have kept the abdominal pain patient out of hospital or out of face-to-face care. I would think at that time, it being a Friday night, wasn't it? Friday afternoon that we were up there. So it struck home to me absolutely what 111 will be missing.
Yeah.
So I thought it was an extremely helpful visit from my perspective, and I think the staff seem to appreciate us being there.
Thank you, Tim. Could I just pick up on the training issue? Keith, Tricia.
Yeah, would you like me to come in on that?
Yeah, that would be helpful.
So all roads lead back to the item on page 9 of our scorecard, where we are 12% understaffed with nurses. That's about 70 nurses out of an establishment of 550. So you're right, training time is factored in to the rosters, but because we are understaffed, certain periods of time have to be cancelled so that we can protect the service, and training is one of those things. As of about now, I think it happened over the weekend, one-to-ones and team meetings are protected. Now they are what we class as red offline time, so they are not protected unless the building's falling in. They are protected, because particularly following on from the open forums, it's very important that we continue to engage staff and give them the opportunity to engage with us and have dialogue with their team leaders. Having said that, whilst we are still understaffed, that will have an impact on performance potentially.
Thanks, Keith. Okay.
Can I just pick up on the
Yeah.
couple of the other points that Tim raised? In terms of health information, we have Anne Joshua working with our health information team within the organisation to try and demonstrate the potential for the inclusion of health information within the 111 service going forward, demonstrating what that might mean, what it might cost, and the value that can be demonstrated to commissioners. I think the basic problem with health information is that people have not thought through, in the context of 111, that which should be provided. It's just, there's a set of broad national guidelines, but when it comes down to the reality, commissioners are getting their heads around the sort of symptomatic parts of 111, but they're not, it's really off their radar, and we're trying to fill that gap with information about, well, you might buy this or you might buy that. On just reinforcing what you were saying on the other point you made about dental, for me, the only doubt is how quickly will we move as a country to re-employ additional dental assessment services on the telephone to prevent patients from, with toothache, going to face-to-face A&E when what they need is advice on pain relief until they can get to their dentist during the next working session. And that is as plain to me. And it's very, very plain to the dental nurses.
Yes.
Who sit there and go, I can't quite believe what's happening.
Yes, and we got that on Saturday, didn't we, Tricia?
We did indeed, yes.
Okay, well, there's a strong theme coming through this meeting, isn't there, about the differences between NHS Direct's current service and 111, which continues to be an open issue.
Yep.
Okay,
this will be illustrated by the results when they come through, of turning off 0845 in Luton. Some of these things will hit the ground in Luton.
When will we start seeing results from that?
When the Department of Health have agreed the release of the data.
Okay.
We had to agree to that condition before the pilot was allowed to go ahead. That's why it took until the 9th of May to get it agreed. So we had to agree not to release any of the data until such time as the department have been able to establish what it means.
When you say not release data, presumably the board can be made aware of that?
Not in public forum.
No.
Not in public forum.
But in private, we can look at that data. It's our data. We can look at it. Thank you. When do you think we might be able to do that?
The pilot's running for 6 weeks and we started on the 9th of May. And we are just finalising the agreements across all parties as how that data will be collected and analysed and reported on. So I would suggest
Certainly
it will
July.
be July, towards the end of July.
Okay, so privately we'll be able to look at it in July. Good, thank you very much. All right then. Shall we then move on to the call recordings for the 3 palliative care situations? Thank you very much for putting those together for us, Trish. They were really interesting. Gave a very good sense of what that service offers.
Yes, I thought we did as well.
Would you like to introduce them and then people may have comments?
Certainly. As requested, the board received this month examples of calls related to patients' experience of the West Yorkshire Urgent Care Palliative Care Service and the subsequent journey those patients or their relatives went on throughout the service we provide. And you'll have heard 3 calls which were from relatives rather than the patients directly, answered by health advisors and then promptly handed over and responded by GPs within that service. And I think they truly reflect the service and the journey the patients or their relatives go on in that service. And I'd be welcome comments from board members.
Was there anybody? I had a bit of difficulty listening to mine, so I heard it this morning. Steve, you weren't able to get it. Sue, you got some, but not all.
Not the last 2.
No. You saw it.
Yes, I was sticking hand, but I've got some comments.
Oh, good. Okay. Okay. So it sounds like a few people have managed to listen to that. So Nick would like to make some comments. Anyone else interested?
Yeah.
Tim, Peter.
Okay. Three comments. I just wonder if there's a less clunky way of organising the collection of the demographics. It just takes so long.
Agreed.
And it just dominated. So it would be nice if we could do that. There isn't perhaps a magic wand, but it would be nice.
A magic wand.
Okay.
Can I put one build on that one as well? I thought in that last call, I think the telephone number was asked for 3 times and fed back incorrectly once, and it just felt to me that the health advisor was talking so quickly that it was going to be very difficult to, it was a slightly noisy background. Just felt it was going to be difficult to get a clear communication. Get it once, get it right, move on, and it wasted best part of a minute and a half, I think.
What struck me though is that our telephony system must deliver that telephone number in front of the health advisor, and why are we not doing it the other way around and saying, is this the telephone number that you're calling from?
One calls the difference.
So it just, anyway, I wasn't wanting to re-engineer the system through the board's discussion.
You seem to be suggesting that there is an answer.
Yeah,
yes.
I've mentioned this before, Chair. In the telephony refresh and further developments within our organisation, with PDS integration, we will have the address and demographic details populated.
And what will we do to make sure that practice changes as a result of that? Because those two things are quite different.
Yeah, it will. Practice, but it's a prime opportunity to influence and improve practice, because the demographics will be there, populated within the record, so then we can use that as an opportunity to say to our staff, here is the demographics, this is really the best way of delivering it. We still have data protection issues where we have to get the caller to confirm their details to us rather than us rehearse it with them, but then there are improvements that we can
So that was my first point. 2 quick others. I thought that, interestingly, the 3 GPs, one used his own way of saying, do I have your consent to look at your records? By saying I've got them open in front of me. It struck me that that process of saying, may I look at the records, it just seemed very odd. And then the third was mobiles, and it's a 111 related issue, which is the son calling on his mobile outside the mum and dad's house for reasons that everybody who's listened to the call will completely understand. The potential if mobiles work the way that we think they will work in some parts of the country, the mobile number will be attached to the 111 service that it first rang, and not necessarily in that situation a son visiting mum and dad would phone on a mobile and get through to a different 111 provider than the 111 provider who covered the mum and dad's area. And I just think it's a wrinkle on the use of mobiles that really needs to be thought through.
But presumably the same thing would happen if the son was calling from home in a different location on behalf of parents who were several miles away.
That would also.
So
it's not just mobile, but it's true.
Yeah, that was an intention that the NHS 111 mobile solution would do that, and that is not the way in which it will be taken forward. But there are some slightly different risks, which is that in certain areas, a call from a mobile at a particular venue may go through to a different NHS 111 service from the call from a landline at the same address.
Yes.
Yeah.
Yes.
So
different variants.
There will be some
mobiles,
potential boundary conditions.
Yeah.
And you can see how much chaos that would have caused in that particular scenario.
So that's the difference between one service and multiple local services. And there are advantages and disadvantages to both. So we're okay. Tim first.
Okay. Just a couple of Nick's points for ones that I wanted to make. The other thing I wanted to observe was just how businesslike the GPs were on each occasion. Very brief, very much to the point. Very cheap, therefore.
Yeah. Don't take that as a ringing endorsement.
But also very human.
Yes, very fine, absolutely. Just like going to see the GP.
But interesting, so I'm going to exercise chair's prerogative, naughty really. But on one of the calls, it was interesting, the health advisor was talking about the patient, and the GP was talking about your mum. And so,
it's very good.
Tim.
Thank you. I agree about the personal details piece. On the first call, the first health advisor call, there was a lot of background noise, and I actually heard a snippet of conversation. I really don't know how that happened, but it's something to watch out. Are people not using their headsets properly, or there's something about some old microphones that are not. And you get these very modern microphones that pick things up locally. So that was the first point. The second point was, when we're referring to a GP, and I've got some personal recent experience of this. These older people, they have a box full of medication, and it took ages, I think, on the second call when the GP came on. Oh, can you tell me what medication they're using? And the son or the daughter, I can't recall, had to go off, get the box, get it out of the box. So the health advisor could have said, we're going to get a GP to call you back, get the medication ready and listed for when he does. And that would have made it a lot smoother and a lot slicker. So I thought that was something that came out to me. So, and then the third call, really, where I think this is just an opinion really, that gentleman was incredibly calm considering the incredibly difficult situation that he was managing. And I wondered whether all callers would be as calm as that, and what training that we've given our staff. I'm sure we have in dealing with difficult calls, and it might be with palliative care. I mean, the stress that he must have been under must have been considerable, and it might just be worth having a look at our training. Does it really cover what that might have been, as opposed to what actually happened?
Peter.
There's not much to add, really. I did think the third GP was extremely empathetic and caring and businesslike, but I would like to have had her as my GP. That was because I thought she was particularly understanding of his problem, and I like that a lot. But all the other points I agree with as well.
Thank you. I also felt that the GPs on those three calls were a masterclass in the combination of, on the GP side, of sort of speed, directness, and empathy combined. And sometimes we think there is a trade-off, but those GPs demonstrated there isn't. That's very impressive. Trish, I don't know if you want to. I mean, there are some things you can take away and think about. If there's anything you want to respond back on, please feel free.
Just Tim's point regarding the medicines, there is within the process, health advisors usually do request, or should request patients gather any medicines together, should the EB need to discuss them. And I do agree with the comments with regards to the masterclass of the speed and empathy. I think, you know, there are lessons to be learnt and have been shared across both professions. The nurses do sit and listen to the GP assessments on occasions, and the GPs take great comfort learning from the nurses as well. So,
great. Thank you very much. Okay, I'm going to suggest we take a short break now and come back in 10 minutes at 20 to 12 to go back to our governance and compliance part of the agenda. Thank you very much, everyone. All right, thank you everybody for coming back. We're starting again in the governance and compliance section of the agenda.
Hello.
Steve has to pay the fine.
£5 every time.
And the first element in the governance and compliance section, perhaps we'll take the two together: board assurance framework and corporate risk register. And Sarah's not on holiday, so she's able to introduce those for us. So that's items 8 and 9 on the agenda.
Thank you, Joanne. I have revised and updated the board assurance framework, and it's now been repositioned to the phase 3 of the Our Future programme objectives. And I've also linked the board assurance framework closer to the performance management KPIs of the board. I have discussed the methodology that I've used with internal audit, and they're very happy with the process that I'm adopting. And this month I intend to take the board assurance framework out to all the directorates so we can understand how the individual and team objectives are, the risks to those objectives will have any impact on the corporate objectives.
Yep.
So the purpose of the position that we are at the moment, I'm just asking the board to note the board assurance framework for this month, but I'm happy to take any questions about the methodology.
Does anyone have any questions for Sarah about the framework or the methodology? No.
I'll comment in a moment when Steve's finished.
Steve, you go ahead and then Peter will comment.
The no change, positive change, are these represent these colours here?
No, in the column status change since last report, when this report comes back to the board next month,
it will have these in. Okay, I get it. Okay.
So this is just to note the baseline position for the year.
Got it. Thank you.
I was just going to say that the dreaded audit committee does keep a close eye on this, and so we'll be interested to hear the detail of the internal auditors' views in due course. So, and if there is anything, of course, we'll comment and let the board know.
Well, I'm sure we're happy to leave that in the hands of our esteemed audit committee.
Just make one very brief comment, which I think Sarah's done a masterful job at getting, because the overall objectives are those in the business plan, but has folded into the report underneath of those, all of those objectives, including those in the Our Future programme. So it's the board scorecard plus the Our Future programme all melded into our strategic objectives. It works really well.
Very good. Okay.
Okay, and moving on to the corporate risk register. We currently have 9 entries on the public version of the register, but I'm pleased to be able to report that we have no red risks on the register this month.
Okay. Any questions for Sarah on the corporate risk, the public element of the corporate risk register? Of course, we'll look at the private element later in the meeting. Very good. Thank you then. And let's have a look at a report back from the Clinical Governance Committee, which Sue's going to introduce.
Okay. We had our meeting on the 4th of May. Some highlights from it. We reviewed the quality accounts and were happy to recommend them to the Audit Committee and Board for inclusion in the statutory accounts, and it gets published on the website as well separately. We received the final report for the CQC compliance review. Previously we had a verbal report, but actually it was very positive reading, and as we all know, we received the highest level of compliance, and there were no improvement recommendations at all, so it's excellent. We received a report, an annual report on patient satisfaction, which as always is, again, positive reading. I guess I'd just like to highlight the Net Promoter Score. We achieved a 77% Net Promoter Score over the full year, and I think that's really very impressive. That basically means that on a question, how likely are you to recommend services to friends and relatives, 77% scored us at level 10, most definitely likely to do so. And that's a sort of level which really is very difficult to achieve. If you then add in level 9, you get to over 80%. So I think it's worth just focusing on those statistics, because it demonstrates that our patients definitely value the service that they receive.
Sue, could I just add there, because it might be helpful, that people saw that nationwide the Net Promoter Score is going to be rolled out for use in other health service settings.
Yes.
So I think it's really ahead of the game.
Yeah. We can't do 111 service, can we?
Do it for any service, yeah.
We don't currently.
We don't currently, but we could.
Wouldn't that be an interesting idea?
The statistic I've seen for the 111 service that must have been in perhaps an earlier Sheffield report was 84% of people said that they were happy with the place they've been sent to, or the disposition that they've been given. Which is obviously, I mean, that's just not is a different kind of measure. So can we take away the question of could we apply the Net Promoter Score using a comparable methodology to the 111 service to compare outcomes? Good.
Okay. We received a final report on the service and quality reviews. They are now complete. Actually, I think there's one still to come to the committee, actually. But the focus of the committee will now be on ensuring that the recommendations are implemented. The clinical governance report focused on monitoring the clinical performance KPIs, and we spent quite a lot of time, as usual, on the expert call reviews, so I was very pleased to see that improving through the board scorecard. And finally, we reviewed and approved the annual plan for the committee. It is of necessity a very high-level plan. Necessity because obviously the organisation will be changing substantially over the period. A lot of the work that the committee does is sort of implicit in the annual plan. So, for example, we will be focusing very carefully on monitoring clinical performance on the 0845 service to ensure there's no deterioration of the service up to decommissioning. And we will, as always, look at the clinical risk register, which covers risks of the transition plan for 111 and also covers in detail the decommissioning plan risks. So it's very high level. If anybody wants any further assurance on the types of things that we'll be looking at on a regular basis, let me know. Or as Louisa did, you're very welcome to come and attend. So get everything first hand.
Very good. Thank you, Sue. Roger, did you want to come in?
We are starting to do some detailed work on decommissioning right across the organisation, so it would be very interesting to link into, probably with Trish, in as to how our high-level plan dovetails with clinical governance. That's an important piece of work, I think.
Okay, I think that was the highlights anyway. Any questions?
Does anyone else have questions or comments to Sue? Or for the executive involved in clinical governance? Well, that's fantastic. The CQC highest level of assurance and no comments. I mean, that really does sound something that we should be proud of, and we should congratulate you and your team about.
I will just make one comment. Again, it's just to really to commend the non-execs' input, having increased the frequency of the clinical governance committee to bi-monthly. What it's meant is, instead of having an enormous agenda and trying desperately to get through it in a far too lengthy meeting, it's now manageable, but it's meant that non-execs involved in the Clinical Governance Committee are upping the amount of time that they're involved, and for which we're grateful, because I think it's a much better has a much better balance to it. There's a much greater degree of, there's more time to just discuss things and to go into a bit more detail. So
good. Okay.
That's good.
Excellent. Living governance. Brilliant. I think then we may have come to the end of our public agenda, unless anyone has any other business to be considered. No? So it just remains then for me to remind anybody who's still with us online, please fill in an evaluation form, and to say that our next meeting will take place here at 10:30 on the 25th of June.